for trauma. And our first presenter is Dr. Sujata Laktakia, and Dr. Professor. Okay, Dr. Khyati, you can please come and present. Her title is Correlation of Inner Segment and Outer Segment Junction Integrity with Vision in Closed Globe Injury. Dr. Khyati, are you there? Okay, if Dr. Khyati is not there, Dr. Ananya can come and present. First presenter is there, Dr. Khyati. They are co-authors. The presenter will only present. If Dr. Khyati is not there, we can start with Dr. Ananya Hota. Dr. Ananya? Third presenter is Dr. Vaibhav Chaudhary. Are you there? Yes. Dr. Vaibhav Chaudhary is presenting on ocular manifestation in patients of traumatic head injury at Tertiary Eye Care Center.
Good morning, respected members. I am presenting my case on the topic ocular manifestations in patients of traumatic head injury at a tertiary care center. Traumatic head injury is a significant public health concern with a wide spectrum of systemic and ocular complications. The visual system, being intricately connected to central nervous system, is often vulnerable to the effects of trauma. By conducting a comprehensive assessment of these manifestations, we seek to understand the prevalence, impact and outcomes of ocular injuries associated with head trauma. Our aim is to investigate the spectrum of ocular manifestations in patients with traumatic head injury admitted to a tertiary care hospital. Our objectives were to categorize the types of ocular injuries and their correlation with severity of head trauma, to determine the prevalence of ocular manifestations in patients following traumatic head injury, and to assess the impact of ocular manifestations on the visual prognosis of traumatic head injury patients. It was a prospective observational study conducted over a period of 5 months from November 2023 to March 2024, involving study sample of 50 patients with traumatic head injury admitted to SVP Hospital Meerut, a tertiary care hospital. This study was carried on all head injury patients, fatal or non-fatal ones, who were admitted to emergency ward or attended IOPD or referred from neurosurgery to IOPD. Since Glasgow Coma scale is used to grade the severity of head injury and assess their prognosis, so it can be used as an indirect predictor of ocular manifestations and its prognosis. Ophthalmic examination included assessment of best corrected visual acuity, pupillary response, extraorbital injury assessment, extraocular movements, anterior segment evaluation with the slit lamp, visual field assessment, intraocular pressure, diplopia charting, and gonioscopy. The data regarding the demographic profile, mode of head trauma, the type of trauma sustained, and the extent of injuries were recorded. CT scan, MRI, and B scan were also done when indicated. Patients were included with patients with ocular trauma in association with head injury. And most of the patients who were included were 10 to 50 years of age. Patients who were not included were patients with ocular trauma cases with intraocular surgeries in recent past or who had pre-existing ocular pathologies causing severe visual impairment. So it was seen that in maximum number of patients, the road traffic accident was a major cause in 58% of patients, followed by physical assault in 22% of cases, followed by other causes like fall from height, sports injury, and a case of animal attack, a case of blast injury, and a case of gunshot. So it was seen that in those patients who are having a GCS of less than 9, the traumatic optic neuropathy due to orbital wall fracture was a major associated ocular manifestation in 60% of cases, followed by retinal hemorrhages and dislocated or subluxated lens. This was a case of a traumatic dislocation of lens in a lady due to a car accident. Another image shows a superior orbital rim fracture seen on 3D reconstructed CT scan causing an impingement on the optic nerve. Patients having a moderate GCS 9 to 12, the pupillary findings were the most common associated findings. In relative afferent pupillary defect was present in 33% of 0.3% cases, followed by lid trauma and other injuries like field defects, nerve palsy, and retinal hemorrhages and corneal aberrations. So this was a case of a lid trauma due to artery. Another image shows a case of a dilated non-injected pupil due to optic nerve involvement with subconjunctival hemorrhage in a patient due to a physical assault. In patients having a mild GCS, a GCS of more than 12, the periorbital ecchymosis was the most common associated ocular manifestation, followed by lid and brow lacerations. And there was interestingly a case of whole globe avulsion. First image shows a 12-year-old child with intraocular foreign body due to fall from height. Another image shows a 14-year-old child with corneal aberration due to blast accident. Another image shows a 32-year-old male presented with a corneal tear after physical assault. This was a case of a 24-year-old girl presented with whole globe avulsion due to car accident. Surprisingly, the patient was having a normal GCS. When the visual outcomes were observed was seen at presentation, maximum number of patients were having a 6 by 6 to 6 by 12 best corrected visual acuity. At the 6 month of presentation, 6 month of follow-up, this number increased to 80%. When the complications were observed, the maximum number of patients were having corneal opacity as an associated complication, followed by uveitis. When the neurological findings were seen, the maximum number of patients were having extracranial hematoma as an associated neurological findings. So from the study, we can conclude that patients having both ocular signs and neurodeficit exhibited a progressively worse outcome as the GCS score worsened. Pupil size reaction are important for initial assessment of head injury, which aids in localizing the site of injuries. The presence of poor visual acuity at presentation, multiple orbital wall fractures, no improvement in vision after administration of steroids. These were the indicators of poor visual prognosis. In the end, it is re-emphasized that the important role of ophthalmic science in diagnosis, progress and prognosis and of neurological patients continues as it was earlier before the advent of CT scan and other diagnostic facilities. Thank you. Thank you.
Okay, so you have included children's also. For any reason you have not included less than 10?
Ma'am, one of the reasons that because children are mostly uncooperative, so we cannot assess the visual acuity or a kind of the GCS also it is hard to interpret from a child.
Thank you.
So you have evaluated second date.
No, sorry?
When did you assess the patient?
Uh,
The day of the admission or the very next
Ma'am,
day?
there was most of the patients who presented in emergency, they were observed at the day of presentation. Some cases were referred from neurosurgery OPD after a few days of
Categorize head injury with the ocular injury or ocular injury with the head injury?
Ma'am, patients who are mainly admitted because of head injury, we assessed what associated ocular. Sorry, ma'am.
Basically, they were admitted patient.
Mostly admitted, mostly were referred from neurosurgery, the kind of reference from other department.
Yes. And one thing you have written anterior chamber hypemia.
Yes, ma'am.
So what do you mean by hypemia?
Ma'am, hypemia is a collection of blood.
Yes. So no need of writing anterior chamber.
Yes, ma'am.
Dr. Weber, as you have taken the patients with head injury, so most of these might have been medico-legal cases, right?
Hmm?
Most of the patients might have been medico-legal cases, right?
Yes, ma'am.
So the patients were primarily admitted under neurosurgery or
Ma'am, primarily under
How do you follow
neurosurgery,
these patients
a case who was presented because of whole globe avulsion was admitted under our department. So there was it was not a fixed there was the different kind of study population. Mostly patients were admitted in neurosurgery OPD, and we received a kind of reference from other
so how
department.
long have you followed these patients up?
Ma'am, we always counsel the patient. We always counsel the patient for a 6-month follow. Means we counsel the patient. We follow up at different time interval, and mostly 6 months of follow up. Those patients who were reported at 6 months, so those patients are included in my study.
So these patients were like of head injury, okay? So have you found any correlation between the and the types of ocular manifestations you found in these patients?
Means, ma'am, there was no clear-cut correlation. Means, since there was a patient of whole globe avulsion, this patient was fully oriented, was have a normal GCS despite having a so grievous injury.
So no much correlation.
No much correlation. Means I just observed what associated manifestations a head injury patient can have in eye.
Okay. And all the patients underwent CT scan had with orbits?
Yes, ma'am. CT scan means CT scan mostly a routine investigation in neurosurgery, neurology.
Yes, but usually they go for CT head only.
Yeah,
So
CT
did you ask them for orbits as well?
Yes, ma'am. CT head and orbit with 2 mm coronal and coronal axial sections.
Shall we move
Thank
to
you.
next presenter? Dr. Khyati is there. Dr. Khyati has come? Okay. So we'll then Dr. Mansi Pandey. Are you there? Please come. She will be speaking on small gauge PPV in chisel hammer injury associated retained intraocular foreign bodies. Her slides.
No, I uploaded there, like the presentation. Yeah, in studio one.
Do you have? Yeah. Dr. Mugdha Sumati is there? Yeah, you can please load the Dr. Mugdha Sumati presentation. She'll be speaking on visual outcomes in page. Yeah, you can go ahead.
Good morning, everyone. My topic is the visual outcomes in the patients of gunshot injuries. The gunshot injuries to the eye represent a Gunshot injuries to the eye represent a significant cause of ocular trauma, often leading to devastating visual outcomes. This study aims to evaluate the visual outcomes and associated clinical findings in the patients with ocular trauma due to gunshot injuries over a 6-month follow-up period. The severity and the type of injury can vary widely, influenced by the factors such as the caliber of the firearm, the distance from which the shot was fired, and the anatomical location of the injury. The study aims to evaluate the visual outcomes and associated clinical findings in the patients with ocular trauma due to the gunshot injuries over a 6-month follow-up period. This was a prospective observational study which was conducted on 24 patients who sustained ocular trauma from gunshot injuries. The study included 24 eyes from 24 patients aged between 21 to 50 years with a predominance of males, that is 23 males and 1 female only. The injuries were classified as open globe or closed globe injuries based on the clinical examination. The 24, this is the same thing enumerated. We assessed on the, in the clinically, each patient underwent a comprehensive evaluation that included the measurement of visual acuity, swinging flashlight test to assess the relative afferent pupillary defect, slit lamp examination for anterior segment evaluation, the fundus imaging for the posterior segment assessment, and the CT scan for localization of the foreign bodies. We got the following results. At the presentation, the following clinical findings were noted. Vitreous hemorrhage was present in 19 eyes, that is 80% of the eyes showed vitreous hemorrhage. 75% showed hyphema or the 18 eyes. The retinal detachment was detected in 20 eyes, 83% cases, and endophthalmitis was diagnosed in 5 eyes or 20% of the cases. The same in the chart form. This is the case which showed the vitreous hemorrhage. The zone of injury was consistently found to be the posterior most, classified as the zone 3 in all the cases. The type of injuries were categorized as the penetrating injuries in the 7 patients or type B, and the perforating injury type D in the 17 patients. This was a patient whose one of the eye was eviscerated, who ultimately landed in end-off, and he was eviscerated, the left eye. But this patient showed retinal detachment with vitreous hemorrhage. In the management part, all the patients received management through the primary repair techniques, including localized lid laceration repair, vitrectomy surgeries, and intravitreal injections. The patients were monitored during an inpatient stay lasting between 10 to 15 days and followed up at intervals of 1 week, 1 month, and 3 months post-injury, and also 6 months. The primary repair was immediate surgical intervention was done. Inpatient stay was for the period of 10 to 15 days, and then they were followed up 1 week, 1 month, 3 months, and 6 months. These are the ocular trauma classification which I did. The open globe injury is classified. The trauma score. Moving on to the psychological impact and the multidisciplinary care. The many patients experience emotional distress due to sudden vision loss or impairment. This aspect emphasizes the importance of multidisciplinary care that includes psychological support alongside surgical management. The gunshot injuries to the eye pose considerable challenges in the terms of management and visual recovery. This study emphasizes the critical need for thorough clinical assessment and timely intervention to improve outcomes for affected individuals. Looking ahead, it is essential to foster the collaborations between ophthalmologists, trauma surgeons, and the mental health professions to provide comprehensive care. Thank you.
So in all you said you had how many eyes? Total?
24 patients and 24 eyes.
So, and you also said that gunshot, it is important the distance from which, so did you have any data about the distance from which they had sustained the gunshot, and was that kind of data available? Or how are these injuries different from other injuries that are sustained? Did you notice any difference between other mechanisms and gunshots specifically? Because gunshots, I presume, are fired with a, they will generate heat.
Yes, ma'am.
So maybe more sterile foreign body. Did you find foreign bodies? Were they sterile? But 5 patients
Yeah.
had endophthalmitis.
Yeah. Ma'am, some foreign bodies were seen in the 5 cases with the intraocular foreign bodies like glass pieces and some bullets. Bullet was found in one case, which was operated in the neurosurgery department itself, and they referred then it to our department.
Yes, so I think that data could have come out, that how many foreign bodies were found, or what kind of foreign bodies
Yes,
were
ma'am.
found.
Yes, ma'am. Yes, ma'am.
And was it available? What distance the gunshot was? Did it make a difference to the prognosis or to the kind of injury they had sustained?
Distance I could not make that, ma'am, because
I
they
think when
didn't
we're
give any
talking about gunshot,
relevant
we can see
history.
that the patient who had a closed globe injury, did he have a different mechanism? Patient who had an open globe
Okay.
injury, did he have a different mechanism of?
Yes, ma'am.
That would be
Yes, ma'am.
interesting.
Mm.
So this is 24 eyes you had.
Yes,
I
ma'am.
mean, this is over a period of what?
Uh, over a period of, ma'am, 1 year approx.
Over a period of 1 year.
Yes, ma'am.
This is from which state from India? Study
From
India.
Ranchi, RIMS Ranchi, Jharkhand.
Okay. Thank you. Thank you very much.
Thank you, ma'am.
Next we have Dr. Mansi Pandey. Are your slides ready? Our slides, please. Any problem? Shall we move with other speaker? Okay, then. It will take time, or shall we proceed?
Good morning, everyone. Today I am going to present a paper on pars plana vitrectomy in chisel-hammer injury associated retained intraocular foreign body. So chisel-hammer injury associated retained intraocular foreign bodies is a major occupational health hazard. It can cause wide range of complications including cataract, retinal detachment, metallosis and ophthalmitis. So surgical intervention, often via pars plana vitrectomy, is commonly required as early as possible to restore vision and to prevent complication. So the objective of our study is to evaluate anatomical and visual outcome of pars plana vitrectomy in chisel-hammer injury associated intraocular foreign body and to evaluate the various predictive factors associated with the outcome. So the population we chose were patients who presented at ophthalmology OPD or trauma emergency of AIIMS Rishikesh and underwent PPP for retained posterior segment intraocular foreign body following chisel-hammer injury. The study design is a retrospective case series. It includes 5 years of time period starting from 2019 April to 2024 March. So patients of any age and gender having metallic intraocular foreign body due to chisel-hammer injury and having post-operative follow-up of at least 3 months were included in the study. So as it is a retrospective study, so medical records of all patients who underwent PPB for retained posterior segment intraocular foreign body between April 2019 and March 2024 were retrieved. All clinico-demographic parameters, including preoperative, intraoperative details, were retrieved and assessed. Then we compare the anatomical and functional outcome at 3 months post-operatively. So these are the following parameters which were assessed to search for any correlation with post-operative visual and anatomical outcome. The pre-operative factors that we assessed were duration of ocular symptom, interval between OGI repair and PPV, best corrected visual acuity at presentation, zone of injury, extent of injury, and other associated complications. The intraoperative factors that we assessed were the impact site of foreign body, lodgement site of foreign body, whether lensectomy was done or not, or were we able to retrieve foreign body or not. The post-operative factors that were assessed were BCV at 3 months, anatomical outcome at 3 months, and was there associated macular scars at 3 months. So there are 3 pictures. The first picture is showing relatively small intraocular foreign body which we were able to retrieve successfully by transscleral route. The second is relatively large intraocular foreign body from macula which we removed by lensectomy, like following lensectomy by transcorneal route. The third image is showing a perforating intraocular foreign body beyond the optic nerve head which couldn't be retrieved by pars-plana vitrectomy due to its deep location and close proximity to neurovascular structures. So when we analyzed result, we found that the total number of patients that we assessed were 29. The mean age group of patients were 29 years. The mean interval between the OGI repair and PPV was 7 days. The maximum patient presented with zone 1 injury. 20% of the patients had end off at presentation, and majority of patients had vitreous hemorrhage at presentation. So we, in the intraoperative findings, we did lensectomy in 82% of the individuals. We were able to remove intraocular foreign body successfully in 86.2% of the individual, and we did it by transcorneal route in 88% of the individuals. The impact site and lodgement site was different in 55.2% of individuals. So we had favorable anatomical outcome, that is retina attached at 3 months post-operatively in 86.2% of individuals, and patients with visual acuity better than 3/60 in 55.2% of the individuals. So we found out that the increased interval between OGI repair and PPV, the large extent of entry wound, vitreous hemorrhage at presentation, and post-operative macular ulcer was associated with worse visual outcome. We also found out that the patient who had pre-operative better visual acuity also had post-operatively better visual acuity. And the only significant factor associated with better anatomical outcome was the absence of retinal detachment at presentation. So we conclude that pars-plana vitrectomy with appropriate adjunct measures significantly improve anatomical and visual outcome in most of the chisel hammer intraocular foreign body cases. Iris injury, traumatic cataract, VH and RD end off were major complications associated with such injuries. The deep-seated intraocular foreign bodies beyond optic nerve head or scleral course may be difficult to retrieve, and we found out that better best corrected visual acuity and absence of retinal detachment at presentation were the only factors associated with significant better post-operative visual and anatomical outcome respectively. As we noted, the increased interval between OGI repair and PPV for intraocular foreign body removal was associated with significantly worse visual outcome, and it is the only modifier factor that we as a doctor's hands have in our hands to intervene. So we should perform PPV as early as possible for successful visual outcomes. Thank you. Yes, ma'am. Post-operatively, we assess after removal. Yes, ma'am. Intraocular. Yeah, after removal, ma'am. After removal, we assess the size of intraocular body. Majority of the intraocular bodies that we found were between 4 to 5 mm. 4 to 5 mm.
Okay, thank you very much. We have next speaker now, Dr. Shruti. Please come. She's presenting an interesting case of ocular splinter in CIOPS area.
Good morning, everyone. May I? Yeah. Okay. Good morning, everyone. My topic is on interesting case of ocular splinter in counterinsurgency in war scenario environment. So the ocular adnexal injuries, both combat-related as well as accidental, are common during CIOPS and proxy war environment, and they are predominantly, eyes are predominantly susceptible to serious injury from high velocity, tiny flying objects, which minimally affects the other parts of the body, but they cause grievous injury when it comes to the eye. So this is a case of ocular splinter in CIOPS area. A 25-year-old serving personnel sustained an injury to his left eye while firing in a unit area. Following injury, he noticed foreign body sensation, watering and diminution of vision in the left eye. He was referred to the center where I was working. So on evaluation, initial evaluation, anterior segment of right eye and everything was normal. The left eye visual acuity was 6/18 with no further improvement. The left eye showed 3.5 into 2 mm. This is the splinter situated with a full thickness scleral laceration sitting over the medial rectus. This is a CT scan, NCCT. It's a 6.5 mm metallic splinter abutting the medial rectus muscle. He underwent wound exploration, splinter removal and primary repair under general anesthesia. This was the foreign body being removed, and this was post-surgical removal. And after that, after surgery, he was evaluated posterior segment. He had a peripheral retinal break and vitreous hemorrhage. He was referred for VR surgeon, and where he underwent barrage laser, and currently is visual acuity. Last time it was 6/9, and the next follow-up it was 6/6. So to conclude is the CIOPS injuries include both combat as well as exercise related injuries. The combat injuries, because it's a tiny object going into all the way back to the back of the eye, and can cause grievous injuries. So early referral, the main issue we face is the transportation of casualty from the site of injury to the referral center. The duration it takes for the patient to reach to me. So that plays an important role. There are times where they do get airlifted, and we will be able to intervene early. Depends on the grievous injury. So this patient was transferred early and I was able to manage. So this is the case. Thank you. Any questions?
What was the duration between the injury, the presentation and the surgery?
Ma'am, 2 hours, ma'am. He reached in 30 minutes, and we routine general anesthesia evaluation, and then we took him for routine 2 hours.
Patient was taken up for surgery, wound exploration, and
Yes.
everything was done within 2 hours?
Yes, ma'am. He came, yes, ma'am, within 2 hours. Entire investigation. The trauma team is set such that as soon as the patient is received in trauma center, the entire team is activated. The anesthetist, the radiologist, everybody comes as a team, and we take the patient immediately. That's how the things work.
Any specific precautions you took while removing the splinter? You said it was lodged into
Yes,
the
ma'am.
medial rectus muscle.
Yes, ma'am, medial rectus. I was cautious, and while resecting also, the peritomy also I was cautious, just looking for if I'm not touching the muscle insertion, and then I was able to remove it and was able to do primary repair completely.
So you didn't have to hook the muscle?
No, I didn't have to hook the muscle, ma'am. Because the one part of the splinter was visible outside, I could pull it out.
Okay, thank you very much.
Ma'am, thank you.
Yeah, so the next speaker is Dr. Sanskriti. Dr. Sanskriti is there? Okay, we'll move on to next speaker, Dr. Deepthi. She'll be speaking on tackling pediatric orbital floor fracture when less is more.
Good morning everyone. My topic for today is tackling pediatric orbital fracture when less is more. I have nil financial disclosure. Pediatric blood fracture differs from adult blood fracture with respect to their unique mechanistic and healing patterns, but still most of them are managed according to adult fracture guidelines. Because of multidisciplinary management, there is a bias which is present between ophthalmologists and maxillofacial surgeons, and there is a huge doubt about when should we operate and what is the exact indication when we should operate a child with blood fracture. The aim of this study was to compare functional outcome between non-surgical and the surgical management of blood fracture in a child and to propose a possible management protocol. 38 patients of age less than 18 years with pure orbital blood fracture were evaluated, including diplopia and Hess charting. CT scan to assess the type of fracture, site of fracture and muscle or soft tissue entrapment was done, and the fractures were divided into Group A, which is trapdoor fracture, Group B, which is floor fracture with incarceration, and Group C, which is depressed floor fracture. All the trapdoor fracture underwent immediate surgery by transconjunctival approach, whereas in non-trapdoor fracture, we assessed the gross motility restriction. If it was -3 to -4, we immediately did surgery, but if there was no gross restriction, irrespective of diplopia and enophthalmos, we did a conservative management till 6 weeks. If there was still a persisting diplopia or worsening of enophthalmos, they were pushed into surgical group. No diplopia in primary gaze or no gross extraocular motility restriction in up gaze were the criteria of the success. Of the total 38 patients, 31 were males of age 12 years, mean age, and the sports was most common mechanism of injury. In type A, as I mentioned before, there were 7 patients of which 5 were web-offs, and they all went immediate surgery, of which 1 patient had a residual 10-degree up-gaze restriction, but 6 were successful. In Group B, that is floor fracture with incarcerated tissue, Of the total 19 patients, 3 underwent immediate surgery, 16 were managed conservatively, of which 14 had a success. The rest 2 underwent surgery because of non-resolving primary gaze diplopia by about 9 weeks. There was no significant difference between both conservative or the surgical group. In group C, similarly, of the 12, 10 were managed conservatively, of which 70% success rate was noted, and there was no gross difference between the outcome between surgical or the conservative groups, and they were managed by about 12 weeks. So totally of the 38 patients, 7 were trapdoor fracture which underwent immediate surgery. But the doubtful were the 31 non-trapdoor fractures, of which nearly 68% could be managed just conservatively, only 32% needed surgery. So we already knew that trapdoor fracture requires surgery, but what about non-trapdoor fracture? When should we surgically, when should we repair them? Should we rely on CT? No. Many studies say that on the CT, the size of the fracture does not correlate with amount of diplopia or enophthalmos. Similarly, the herniation of the soft tissue, what we see on CT, does not correlate with diplopia or enophthalmos, as many children still don't complain of diplopia despite a large herniation. So what new did we find in our paper was, in non-trapdoor fracture, it is not the CT which decides the surgery, the clinical signs and us ophthalmologists who decide the surgery. Gross motility restriction, immediate surgery is needed, but in case of there is no gross motility restriction, we can wait up till 6 weeks with, if there is a persistent diplopia or enophthalmos, only then they can be undergoing surgery. Am I justified in this wait? Yes, many studies from radiology department have proven that the children's bone undergoes remodeling, and because of which the bony growth by about 6 weeks can resolve diplopia and enophthalmos spontaneously also. So to conclude, non-trapdoor pediatric fracture, we can still delay the surgery, and if we are doing the surgery, a transconjunctival incision can be used. This is the protocol. These are our references. So in pediatric orbital fracture, less is the new more for a non-trapdoor fracture. Thank you.
Thank you very much, Dr. Deepti. Your slides were very good actually.
Thank you, ma'am.
There was no identifier in the patient photos, etc. And anything else?
In case of pediatric adult fractures, there are more of non-trapdoor fracture. There are not much of trapdoor fractures available there. It's no white-eyed blood fractures are seen in case of adults. And in adults, it is more of external manifestations where we see gross, the proptosis and huge ecchymosis. All those because our bones have already grown up. But that doesn't happen in case of children. So every child, if there is a history of trauma and if he says he is somewhere bradycardic or nausea vomiting, we need to still suspect the fracture part. Yes, ma'am. Thank you, ma'am.
One
Yes.
question, Dr. Deepti. You have included children around 5 years of age as well in the study.
Yes, ma'am.
So how did they complain of diplopia?
Children, no, they don't complain of diplopia. They were picked up. Actually, there were 2-3 children who were sent to neurologists because they had nausea vomiting. And when the neurologist did CT, they picked up the floor fracture with the trapdoor, and then they were referred to us. But under the PICU guidance, then we had to, vasovagal had to be managed, and the next day we performed the surgery. No child of 5 years or 3 years with Weboff comes to us directly as a blood fracture.
Because you included it as one of the factors, right, for conservative management, that
Yes.
irrespective of diplopia or this. So a child of 5 years I
No,
think
that would be not, yes, ma'am.
was referred to you.
Yes, ma'am.
The next speaker is
Thank you,
Dr. Hazika Zahoor.
Good morning everyone. I will be presenting on the incidence of secondary hemorrhage following traumatic hyphema at a tertiary care center. Starting with the introduction, hyphema means presence of blood in the anterior chamber. It may occur in isolation or along with damage to other ocular structures. Patients with hyphema usually present with blurred vision, pain, photophobia and lacrimation. Incidence of hyphema has been estimated to be around 17 to 24 per 1 lakh population. Even a small hyphema due to ocular injury can be a sign of major intraocular trauma with associated damage to vascular and the other intraocular tissues. Secondary hemorrhage is one of the greatest concerns following traumatic hyphema. Eyes that develop secondary hemorrhage have a higher complication rate as compared to the eyes that don't develop secondary hemorrhage. The rate of rebleeding varies from 3.5 to 38%. Coming to materials and methods, it was a hospital-based prospective observational study which was ophthalmology GMC Srinagar. Patients were followed up for a period of 6 months. Inclusion criteria: all the patients more than or equal to 10 years of age with traumatic hyphema due to blunt ocular trauma, patients with adequate follow-up of at least 6 months. Exclusion criteria were patients with penetrating ocular trauma, patients with hyphema due to causes like rubiosis iris, iris melanoma, blood dyscrasias, and sickle cell anemia. Patients with hyphema following intraocular surgeries. Proper history was taken with regard to age, gender, occupation, nature of ocular trauma, activity at the time of injury, time duration between the occurrence of injury and presentation to the hospital. Symptoms at the time of presentation were recorded. History of any systemic illness like diabetes, mellitus, or hypertension was noted. Coming to results, age of the study population ranged from 11 to 65 years. 50% of the patients fell in the age group of 10 to 19 years. Mean age of study eyes was 24.77 plus minus 12.7 years. This is a table that shows distribution of cases with respect to the mode of injury, with sports being the most common mode of injury, followed by occupational causes, and injury due to fall being the least common cause of injury. In our study, incidence of secondary hemorrhage was found to be 7.5%, with 6 patients out of a total of 80 patients studied developing rebleed. This is a table that shows distribution of study eyes with respect to the grade of hyphema. Maximum number of patients were seen having grade 1 hyphema, and there were only 3.75% patients with grade 4 hyphema. Distribution of rebleed patients with respect to the grade of hyphema. Our study showed that with increasing grade of hyphema, there is increased risk of developing rebleed. The p-value was found to be statistically significant with a value of less than 0.05. Coming to discussion, majority of the patients enrolled in our study were adolescents. The possible reason for this is that the younger individuals are more active and enjoy participating in vigorous outdoor activities like sports, and this has been correlated with the studies conducted elsewhere. Most common mode of injury in our study was sports. That is also being correlated with the studies conducted by NG, CS et al., Cairns, Patrick, Philippus, Mohan, RPT, and the incidence of secondary hemorrhage being 7.5% has also been studied in the other studies as well. Our study found that secondary hemorrhage was more common in the patients with higher grades of hyphema, as has been seen in other studies as well. Coming to conclusion, secondary hemorrhage is the most concerning complication of traumatic hyphema, which can worsen visual prognosis and increase the risk of long-term complications like corneal blood staining and glaucoma. Factors like higher initial grade of hyphema and inadequate eye protection resulting in more severe injury are associated with increased risk of developing rebleed. Proper preventive measures and early treatment can reduce the incidence of secondary hemorrhage, thereby improving patient care and visual outcome in these patients. These are a few pictures of the patients who developed rebleed. The first picture is showing a patient of grade 2 hyphema who developed secondary hemorrhage, and the second picture shows a patient with a grade 4 hyphema who developed rebleed. These are my references. Thank you.
So what was the timing at which the rebleed had occurred?
It actually occurred, ma'am, at on third day.
So for your patients, do you have any data available, like when did they have the rebleed?
Yes, ma'am.
We've not,
I have not included that in that because the primary part I had studied that was included in the different papers.
also data whether any of these patients were on any anticoagulants.
Yes, ma'am. The patients who were on anticoagulants were excluded from the study. They were not included.
They were excluded.
They were excluded. The patients on anticoagulants were not taken into consideration.
Shall we?
Secondary grade is more severe or primary grade?
Secondary grade.
Shall we move to next presenter? Actually, we have still 3 presenters, no? I think 4 or 3. Okay. Dr. Khyati is there? Has she come? Okay, then Dr. Ananya Hota. Then Dr. Sanskriti has presented. No, Dr. Sanskriti has not come. Dr. Sanskriti is there? Okay, then I think. आप बोलो। ये भी है okay 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 so one more presenter we have actually for best paper, huh? Dr. Shruti. Dr. Shruti is there?
14-15 session. No, this is 11 o'clock, no? 11 to 12:15 trauma finals. Trauma to finals. This is the trauma to finals.
Yeah
11 o'clock. It is now.
she'll be presenting on ocular trauma and counterinsurgency and proxy war environment, epidemiological study 2008 to 2023. Please continue. समझ में नहीं आया इसको, मुझे ये कहाँ से आया?
No, ma'am. Major Shruti, Dr. Shruti.
Yeah, you can continue, please.
Yes, ma'am. Okay. Good morning, everyone. I'll be presenting on ocular trauma in counterinsurgency and proxy war environment. It's an epidemiological study from 2008 to 2023. It's about 16 years of data. So, military personnel across the globe are highly susceptible to either ocular injuries, and then there's a significant cause of morbidity associated with other severe injuries, even mortality as well. So these injuries can be because of routine military exercises, the road traffic accidents, assaults, or even sports and recreational activities. The high velocity projectile with tiny glasses and fragments cause injuries to the face of soldiers in intense explosions. So the trend of eye injuries in combat from when we consider from Indo-Pak war, when it was hand-to-hand combat or slightly not advanced weaponry, it was only 3%, and it kept on increasing to 4.8 in Indo-Pak war 1971. The Sri Lanka peacekeeping war was 1987 to 89, it was 10.5. In Iraq-Afghanistan conflict, it increased to 15.8. So this is the data. So the objective of this study was to analyze the epidemiology of hospitalized ocular injuries occurring in the counter-insurgency and proxy environment in the forward areas of northern India over a period of 16 years. It was a retrospective observational study of medical records which was performed of 948 patients with ocular injuries primarily treated at a zonal hospital of Indian Army between January 2008 to December 2023. So the factors which were considered in, as mentioned in the previous presentation also, the factors which considered in the management of patient is the casualty transportation, how early the patient reaches you, and the widely variable evacuation time, whether they're in a place where they can reach you immediately, or despite having the severity of injury based on the priority key, whether it's a red injury, maybe priority 1, 2, 3, we grade it and then decide. The next is medical equipment limitation at the peripheral setup. So this is eye trauma which we received at our center over a period of 16 years from 2008 to 2023. So when you see this, the incidence of open globe injury has decreased. The red are closed globe injury. The incidence of closed globe injury has been increasing. The based on the mechanism of injury, the blunt trauma, the splinters, IEDs and firing, these were the causes of closed globe injuries. And in open globe injuries, firing, barbed wire, the most common thing, and blast and splinters, and blunt traumas and stone pelting. So these are, how do we prevent, is to, we give the soldiers protective goggles to prevent eye injuries. That's one way we can, even though the face, the size of such a small splinter falling somewhere over the body will not cause a severe injury, but it goes to the eye, it goes all the way back to the posterior segment. So the take-home message here is the combat-related injuries are on the rise because of advanced machinery, weaponry, and preventable. And these are injuries which can be prevented, and military combat eye protection devices can reduce the incidence of eye injury. These are my references. Thank you. Any questions?
You can ask.
So this data was like from 2008 to 2023?
Yes, ma'am. Yes, ma'am. 2023.
The long period.
Yes, ma'am.
So do we have any subset analysis also, any change in pattern in the injuries between,
Yes, ma'am.
let's
Yes,
say 2008 to 15, or you know?
Yes, ma'am. The things with the present data that I'll be publishing is the injuries of open globe has incidence is decreased, and the closed globe injury is increased, and especially from 2018 and afterwards, if you can see, the incidence of the recreational activity and exercise activity is increased than compared to the stone pelting and other the active combat injuries is decreased in the last 4 years.
Okay, one question.
Yes, ma'am.
How do you, like, when you operate some such patient, how do you post-operatively find out whether there is any left foreign body or not?
Ma'am, we have set up, ma'am, a CT machine is there.
So you go for a post-operative CT?
Yes, ma'am. We do consider. Yes, ma'am. There are, in the case which I presented earlier, in the previous case, despite foreign body removal, when I referred him to VR surgeon, he got the repeat NCCT done just to see if there is any remaining foreign body. So we do take up for repeat CT if required.
In all types of foreign bodies?
Ma'am, all splinters, mostly from gunshot or UVGL, blast, they are the cases. Thank you.
Thank you very much. So we come to the end of this session. Yes. Thank you to all participants and chairpersons and judges. Can we have a group photo, please? Chairpersons, please. Speakers also, please come forward.